Hello, my name is Jorge Cortes, and it's my pleasure to give you a summary of some of the clinical data that was presented at this recent John Goldman CML meeting from ESH and International CML Foundation. It's impossible to do this in just this short period of time that we have now because there was great information presented in the oral sessions, in the posters, even in the Meet the Expert sessions. But I want to give you a little bit of a glimpse of what we had at the meeting. Let me start with some of the new drugs information that was presented at the meeting. And one important study was the study for Olverembatinib. We know Olverembatinib has already shown in a variety of studies that it has a very potent activity and very good efficacy and safety in patients with previously treated CML, and the drug is actually already approved in China. It's undergoing a pivotal trial in the US and other countries. It is a ATP competitive inhibitor with good activity in vitro against T359. The study that was presented this time was a study for second line therapy, which is important because most of the studies, again, have included largely patients that have received 3 or more TKIs. So in this study, patients could have received any of the approved TKIs. It was done in China, so that included imatinib, nilotinib, Vamotinib, or dasatinib, and they were treated with olverembatinib at 40 milligrams every other day, and with the primary endpoint being the rate of complete cytogenetic response. And the rate at this point was, with a median follow-up of only 16 months, was 74%. So a very good response rate considering the relatively short follow-up, and also with a major molecular response of about 40%. Importantly, the response rate was similar, or if anything better, for patients that had received a second generation TKI as opposed to imatinib, and also a very good response regardless of whether the patients had mutations or not. And the safety profile matched what had been reported for this drug, meaning some myelosuppression, not a whole lot. It's not very myelosuppressive, it appears. And other than that, in non-hematologic toxicity, mostly skin hyperpigmentation, which is in the form of hyperpigmented nevi. And most of these toxicities were grade 1 or grade 2. Another interesting drug that was presented is Vamotinib. Vamotinib, you may have heard about as a PF114. The data from the phase 1 study was recently published. It's a drug that is also ATP competitive. It was based on the molecule of ponatinib, and the initial data from the phase 1 had shown some interesting results with good efficacy rate of complete cytogenetic response of 20% in patients that had been very heavily treated. And in this study, this was a randomized study of patients that had received a prior therapy with imatinib. So it's also a second line study. And patients were randomized to receive Vamotinib or a dose escalation of imatinib. Now, we need to keep in perspective that the study was designed with whatever was available and possible. So, although we don't mostly consider dose escalation of imatinib, I think it still provides us with good data for the efficacy of Vamotinib. And the results are also very attractive. At 12 months, the major molecular response rate was 47%. And at 6 months, the rate of MR2, so the equivalent of grossly a complete cytogenetic response, was 59%. There were also some deep molecular responses, 27% MR4, 23% MR4.5, with patients with a variety of mutations showing some response. The safety profile was good. Very little in terms of myelosuppression, which is again very interesting. And largely, the main problem was skin toxicity. 63% of patients had skin toxicity, although it's overwhelmingly grade 1 or grade 2. So an interesting drug. Of course, we want to see additional data. We want to see how it may compare to other second generation and third generation TKIs, but nevertheless, very interesting molecule. And the third drug that I want to discuss is the Enliven ELVN-001. This is another ATP competitive TKI, a very novel that has a very high selectivity, very minimal activity against other kinases, which makes it very attractive. Also, it has advantage that it has very few um, drug-drug interactions, no food interaction. So this study was a phase 1 study that looked at the dose escalation and the maximum tolerated dose. There's already 90 patients included on this study, and many of these patients, just because of the timing, have already received Asciminib and or Ponatinib, so heavily treated patient population. 25% of the patients had actually received 5 or more TKIs. Well, with the data that was presented with a median of 29 weeks of exposure, 80% of patients still continued on therapy, and there is some good evidence of efficacy in these patients. By 24 weeks, the rate of major molecular response is 47%. Um, that included achieved and maintained, but the achieved was 32%. And there was responses about that same response rate in whether the patients had received Asciminib or Ponatinib. So that is very interesting, considering that those patients had received very good therapy already. And there's also very minimal toxicity, mostly lipase elevation, diarrhea, but all of that is less than 20%. So possibly that selectivity is really translating into very good safety profile. So very important to follow up these drugs as well. A very attractive though to continue. Now, Asciminib is not exactly a new drug, but there were some additional studies that were presented that I think provide additional data that's valuable. One is the study As to Escalate, which is a second-line study for Asciminib on patients that had received any initial TKI and were resistant or intolerant. This included 100 patients. The initial interim analysis had already been presented, but there's here additional follow-up, and it shows that the rate of 1% or less transcripts by 48 weeks is 78%, and the major molecular response is 56%. Very good response compared to what we have seen with, for example, second generations after imatinib only. And the response rate is similar whether the patients had lack of efficacy or lack of tolerability in as their eligibility criteria. There were even 25% of patients with an MR4 and a little over 10% with MR 4.5. Importantly, there was a safety profile that was very similar to what I've seen. If anything, a little bit less. Hypertension, 10% is the highest grade 3 toxicity. So this supports the use of Asciminib as a second line, as well as we've known the data for front line and for third line and beyond, when patients have received some other initial TKI. Another interesting Asciminib study is the study from that's called Ask for Opt. We have used Asciminib largely as a 40 milligrams twice daily, but because of convenience, since it requires fasting, some patients may receive 80 milligrams once daily, and we've always considered these doses, these schedules equivalent. So in this study, patients were randomized to receive 40 milligrams twice daily or 80 milligrams once daily. And these was for patients that had received 2 prior TKIs or more. It's a good sized study with 169 patients randomized. And the great majority had received 3 or more tyrosine kinase inhibitors, so at least 50% of the the patients. And the rate of major molecular response at week 96, so grossly the 2-year data, is very similar. 45.8 so with 40 milligrams twice a day, and 41.5 with 80 milligrams once a day. So suggesting that the doses may be indeed interchangeable. The deeper molecular responses so far seem to be a little bit higher with 40 milligrams and 80 milligrams, but we need to see more follow-up. In terms of the safety profile, it's pretty much the same with either one of these doses of administration, and very consistent with what we know for these drugs. So very clean safety profile. So important to recognize. Of course, we want to see the additional data to feel further confident about these once-a-day dosing. Another interesting study that was presented or updated was the ASC4START. This is another frontline study of Asciminib. This one is compared directly with Nilotinib as initial therapy. But this mostly focuses on the tolerability of these drugs. So the primary endpoint is a novel trial, a primary endpoint that's called time to treatment discontinuation due to adverse events. There are, of course, other safety endpoints and efficacy endpoints, but largely focusing on this tolerability issue. A large study with more than 500 patients randomized in the study, and it shows that there is a very significant benefit of Asciminib in the time to treatment discontinuation because of adverse events with a hazard ratio of 0.45. The number of events were less than 6% with Asciminib, 12% with Nilotinib. So a clear benefit for Asciminib in terms of the safety profile. And another series of studies that were interesting, a couple of studies that are attractive, are in terms of the use of dose reduction as a possible strategy for some patients. One of them is the HAF study from our colleagues from the Czech Republic, like by Daniela Sakova, and in this study, patients received the standard dose. They should have had it for at least 4 years. Then they received half the dose for 6 months, then another half the dose for another 6 months, and then they could have a stop in the therapy. So the study has shown it has a large number of patients, more than 200 patients, and it showed most of these patients had received were receiving imatinib, and most of them were receiving first-line therapy, have been followed for a median of almost 3 years. And what very few patients have withdrawn from the study, only less than 8% of the patients. And the molecular recurrence-free survival after stopping therapy was at 24 months was 69%. Most importantly, after the first dose de-escalation, there were no recurrences. After the second dose de-escalation, the recurrence-free survival was 90.7. So most patients held the response. And then after discontinuation, the data that we really know and expect. It was interesting that men did a little bit better than women in terms of treatment discontinuation. And they suggested that there was a genetic profile that can predict for that, for the treatment discontinuation being sustained response. The safety profile, as you can imagine, the adverse events decrease with the discontinuations, and then of course with the with stopping therapy. So very interesting approach for these patients. Another study that was called the RODEO study, and this was a survey. So this is a survey of 360 patients, and to see how the outcome can improve with the dose reduction. So they were patients in chronic phase with MMR or deeper that had received first or second generation TKI. and then there was a shared decision about a dose reduction. Um, and it just showed that the patients really welcomed the de-escalation, with very few patients having to re-escalate their treatment. Only 2% of patients lost MMR, and most of them were able to do the dose de-escalation. So, very, very interesting data of something that we're doing more and more. One very important study that I found fascinating was the use of these spot-on CML, as the name of the study, which is using dry blood spots in paper to assess molecular data in poor and low and middle income countries, where they can get the sample, put it on a piece of paper, send it to a reference lab, which in this case was the Fred Hodge. This study comes from Vivian Oller and Jerry Radich. And they had already shown that they can do these for BCR-ABL, but here they did it. They expanded these to the detection of mutations, and they found ABL mutations in 177 patients. 74 different mutations were detected. 11 patients had multiple mutations. Very attractive, including some multiple mutations in a few patients, and also mutations in other genes, ASXL1 and so on. So this is a fascinating technique, just because it opens the possibility of these being more available to other countries where they may not have the technique there locally, but these dry spots can permit to do this assessment at a distance. Finally, a couple of studies on pediatric. One is the outcome of patients with children with CML from the German study, looking at the dynamics and the outcome of second-line therapy, and they included 212 patients, and looked at specifically at the Dasatinib cohort to see their outcome. What they found is that they had an improvement in the response rate with the change of therapy, very much what you see in the adults, but because of the very difficult the difficulty in conducting studies in pediatrics, this is very valuable. Most of these patients had to change because of response issues, so rather than intolerance, and they show the benefit of this intervention in pediatric patients. And finally, a very good data from also in pediatric on TFR in children. This comes from our colleagues from India, Dr. Nirmalaya Roy Mullik, again showing a cohort of patients, 61 patients for a pediatric study. This is impressive. That with a median age of 11, that goes all the way to 15, and that have been in remission, and the TFR rate at 12 months is 68.9, at 24 months is 64.5. There was withdrawal syndrome in only about 13%. And of the patients who lost the response and restarted the therapy, which is 37%, most of these patients regained their molecular response. So the cumulative incidence of regaining MMR was 78% at 12 months. Very important data, because, of course, this helps support this approach in pediatric patients. So again, very difficult to reflect the whole breadth of the conference, which was outstanding, and of course all the discussion, the conversation, which is very rich in these meetings. But hopefully this gives you a bit of an idea of what a great meeting this was from the clinical perspective, but as you will hear from Danielle as well, also from the basic perspective. So thank you very much for your attention. We hope to see you at the next meeting in Sweden.